AI is obviously going to be one of the topics that is a constant throughout the next 2 days. AI has moved obviously from the hype and experimentation into implementation throughout the healthcare system and elsewhere. With that acceleration has come a lot of concern about the trust, the transparency, the privacy, and the safety, and that friction between humans and machines, of course. So today we're going to speak with a company that has moved beyond that into safe, reasonable implementation in practice. And it's my great pleasure to introduce you to the co-founder and the CEO of Lyrebird, together with the Chief Clinical Officer, and that is Kai is the CEO, Kai van Lieshout, and the Chief Clinical Officer is Ray Boyapati. Thank you very much. They're diamond sponsors of the DHF.
Thank you so much. Hello everyone, my name's Kai and I'm the founder and CEO of Lyrebird Health. We're on a mission to extend the human health span by helping healthcare work better by building AI tools that enable that. Ray, do you want to introduce yourself?
Sure, thanks Kai. I'm Ray, Chief Clinical Officer at Lyrebird. I'm also a gastroenterologist, and so just like many of you in the audience here, I'm seeing patients every week in the clinic. My job's really to ensure that what we build works in real clinical practice, and not just in theory, not just in general, but in the actual consultation room with a real clinician, real patient, and real impacts on care.
So this is our 4th year at DHF. In 2023, which was our first year, we were in the back corner of Startup Alley, probably so deep that you wouldn't even see it, basically. And I kind of remember it was just like a 1 meter booth, and we were the only scribe at DHF. Can you imagine, right? And we spent the majority of our conversations explaining that AI could now, in fact, do the paperwork for you. And so a little bit's changed since then. AI has quickly moved into bigger, oh, do we need the clicker? So AI has quickly moved into bigger and more important parts of the healthcare stack. It's now driving decision support, workflow automation, and agents as well. And so by comparison, that AI scribe that just writes your notes can sound pretty simple, right? But looking back, I don't think it ever was. Even a seemingly simple clinical note has a meaningful impact on the way the care is delivered. It becomes part of the patient record, the basis for what gets followed up, referred, and actioned. And so even the simplest version of this technology was already meaningfully impacting care. And now these tools are moving further and further upstream, right? So they're closer to how care is prioritized and delivered. And so from a product perspective, these seem like really incremental steps. A better note, a new document, a workflow, a little suggested action here. And so you might not think that much of it. But clinically, the downstream impact is exponential. A faster referral, a quicker diagnosis, these all make a tremendous difference on healthcare. And so the stakes of getting it right or wrong grow exponentially as the product evolves.
And from where I sit in the clinic, these tools seem categorically different to anything else I've ever experienced in medicine. So my AI, EMR, that stores information. My referral system moves it from A to B. But artificial intelligence, that's capable of generating clinical content at scale and in real time. And this content can actually shape what a clinician sees and how they act. So just think about what that means in practice. The opportunities are certainly great and pretty obvious. Take one common point of failure in the hospital system. If anyone's been anywhere near a hospital, you'll know this, the point of discharge from the hospital. So patients leave without enough information. They don't know who to call, how to call, where to call, when to call. And even when they do, the hospital line's engaged, the email gets unanswered, the clinicians are not available. So people fall through the cracks here, and it seems like this is a perfect opportunity for AI and systems to improve this and improve patients' outcomes. So let's play it out. The patient's discharged from hospital, and 2 days later, the AI system picks up a call. The patient's got shortness of breath. That sounds great, and books them in to an appointment in 2 weeks' time because it sees this as routine post-admission care. But the system wasn't connected to the clinical record. It didn't know that the patient had surgery, and it didn't have the clinical reasoning to know that surgery significantly elevates the risk of pulmonary embolus in this patient, clots to the lungs, or that shortness of breath is a cardinal symptom. So that's a potentially catastrophic miss. So the opportunities here are enormous, but in medicine, when the stakes rise, when the risks rise, the standards rise with it. So we do this to protect our patients, and the same must be true here. And that's something that Lyrebird learned early on.
And so Lyrebird started writing clinical notes, as I said, but we pretty quickly realized how connected notes are to everything else in the healthcare stack and journey. So referrals, care plans, billing, and how much that varies by specialty, region, clinical setting, and patient population. And so what we learned really quickly, and something that's so crucial when these tools seem really generic, like even just the category term of an AI scribe, is that essentially these can't be generic. So something generic just can't safely support clinical work and will definitely cause harm because you need to understand the context of the clinical environment that you're operating in. And so there's one example that stands out really strongly to me from quite early on when we started. The tooling wasn't as advanced as it is now. And I remember that in some rural settings, these doctors were telling us that it wasn't reliably documenting the social history screening for certain Indigenous patients. And so we obviously spoke to them, and we wanted to understand why this was happening and how and what was driving this. And so when we spoke to them, they said that they would screen alcohol consumption differently for certain patient demographics. And their exact words were, instead of saying something as direct as, how many standard drinks do you have in a setting, it would be, what's a good night of drinking for you? And so Lyrebird was interpreting this as social chat. And again, this was in the early days, but it's really important because it was essentially was interpreting it as just a casual social conversation rather than an intentional clinical data point that's just simply screened differently depending on the care setting. And so this was just one example, and we obviously solved it really quickly, but it exposed something incredibly important about the vastness of what correct looks like for even just a simple subsection of the notes, which is social history, right? Depending on the patient population. And it's so important that these tools serve all different patient populations equally, right? And there's a potential for a huge amount of, effectively inequality to come from this as well. And so we were able to catch this because we had two things in place. The first was enough real-world use for this kind of variation to actually surface. And then the second was the clinical feedback loops to detect it and recognize why it mattered and make the changes to stop it from happening again. And so that example's really stayed with us because it showed just how easy it is to miss context in healthcare. The clinician had already done all the clinical work and all of the hard work, to be completely honest with you, and all the AI had to do was recognize what happened and document it correctly. And as I mentioned, this is only going in one direction, right? So these tools are moving further upstream into triage, follow-up, care planning, guideline support, billing, and the systems, as Ray said, that determine what happens after the patient leaves the consult room. And so what this means is that the risks effectively multiply exponentially again. And it's no longer just a question of did the AI capture what happened correctly, but it becomes did the AI understand the clinical context well enough to help shape what happens next safely. And so the future of clinical AI will be defined by those who earn the trust in the clinical setting that they serve and keep earning it as the technology takes on more responsibility. And so purpose-built AI is not something you build once and kind of declare finished. It's actually something that you need to continually keep earning as the product is used and evolves in the real world.
And the sheer breadth and variation of how medicine is practiced, I just don't think is understood by people outside of healthcare. So the rural GP practicing chronic disease management in Queensland, the busy surgical outpatients department in a metropolitan hospital, the paediatric ED at 3 in the morning. These aren't minor variations. These are completely different clinical contexts. So they're different ways of working, different patient populations, and different terminology. These have different clinical risks. So an AI tool that's built generically might work in one, but might get it dangerously wrong in another. And a clinician using it may just never know about it. So I think the solution here is not to scale without intent. That just compounds the problem. There are more clinical situations that you don't understand, more patients where you're getting it wrong without even knowing it. So you need to be deliberate in where you go and what you do and how you do it and what you don't do and where you don't go. The solution is to scale deliberately. And in medicine, we know this intuitively, right? A doctor doesn't specialize on day one, but they don't go and train in pharmacy, and also they don't go and train in veterinary science either. So you go broad within your discipline, gain experience and gain that clinical judgment, and then you go deep. It's the breadth that enables the depth, but only if it's done with intent. And that's how we think about building clinical AI. You need enough exposure across enough clinical context to understand that variation. But you don't try to be everything to everyone. You learn insights from the scale, and then you go deep where it matters most.
And so this is also core to how we think about deployments. So in May already this month, Lyrebird will have helped make documentation easier for well over 1 million consults in Australian general practice alone. In the NHS, we're rolling out the UK's largest deployment of clinical AI across 20,000 clinicians in the South West London Integrated Care Board. And so this scale reflects a level of confidence in the product and the systems around it. But it also increases the responsibility because more clinicians means more contexts, patients, edge cases, and places where the product needs to keep understanding the reality of the care that it's in. And so scale matters, right? But it's only if you use it properly. More data points and more scale can give you more confidence, but it can also make you overconfident, right? And so part of building this responsibly is actually looking for where your product falls down, like that example that I mentioned earlier, and that's why we're sharing it here, right? Not to hide something like that, but actually to call it out. And it's the systems that enable us to identify that and solve it that are so crucial. And so one example of where we did this, and its external verification has been really important for us, is with our deployment at the Gold Coast Hospital. So it's the largest deployment of ambient AI in an Australian hospital setting, now with well over 1,500 active clinicians. And Gold Coast kind of came to us and said, hey, we want to run an independent peer-reviewed evaluation and publish it. And so we said yes, and definitely not because we knew what the kind of analysis was going to say, but because we wanted it and deeply believed that it should be published anyway. And so, Ray, when the findings came back, what stood out to you?
Yeah, well, firstly, my reaction was excitement. I think we need much more of this rigorous real-world research in this space. But I was also just interested in the findings, and they were interesting. So as you can see on the screen, there were really strong efficiency gains for clinicians. There was time saving. Patients were reporting more direct time with their clinicians, and Lyrebird notes actually scored higher on average than the clinician written notes on a validated quality instrument. So that all sounds great, right? Well, let's look a little bit deeper. So on a visual representation, the red curve here represents the clinician written notes. The blue curve, the Lyrebird written notes, and the green where they overlap. So yes, Lyrebird did score at higher on average on the PDQI-9, but not better all the time. And over 16 weeks of real-world evaluation in a number of different specialties with dozens of clinicians, a number of them found something that didn't quite look right in the note, at least once. Not commonly, but at least once. In medicine, you can't just average out a clinical signal like that. You have to understand it. Now, Lyrebird's changed a lot since this research was conducted, but it doesn't make these findings any less valuable. What this showed was how clinicians are using this tool in real-life settings, and that can't be seen necessarily from the inside. That's exactly what independent real-world research is for, and we understand this in medicine, don't we? In clinical trials, each phase can uncover something that can't be seen in a previous phase. And sometimes things can only be visible when it's embedded in real-life practice, across enough contexts and over enough time. But evidence alone isn't enough. You actually have to do something with it. So it says there, define the standard, but in medicine, you don't get to define your own standard, right? We've got guidelines, we've got professional bodies, and we have peer review. And that infrastructure obviously exists because the stakes are so high. In clinical AI, that infrastructure is still being built. But someone has to start, and I think you can only set a meaningful standard if you've done the work. If you've built the research, if you've built the scale, and you've seen what's missing. And so we've done that. So we asked ourselves, what does good actually look like here? Now, there's no industry standard here for this yet, so we built and published our own. So the clinical evaluation framework is one example of what that can look like in real practice. The framework asks clinicians not to rate the note from 1 to 5, but to find specific, discrete, countable errors. Was there a hallucination? Was there an omission? Because a score of 3 out of 5 or 4 out of 5 doesn't actually tell you what went wrong, whereas countable errors give you something you can actually act on. Now, for hallucinations specifically, not all of them carry the same risk. Any of the clinicians in the audience here will know this. And an evaluation framework needs to take that into account. So, an example, a patient mentions they've got an injured knee. They've had to take time off work, they tell this to the clinician, and they've been resting it at home. The note records limited mobility due to knee injury. Now, this patient never said that specifically, but most clinicians would find that reasonable. Now compare it to the note that says patient denies allergies when the patient actually reported a penicillin allergy. Now that's a contradiction and dangerous. So any framework that treats this in the same way is not measuring quality meaningfully. And what we've found is actually that most errors are not a model problem necessarily, but a context problem. It's the same lesson that Kai was speaking about earlier in the example. And if you're not close enough to the clinical context, if you don't have those feedback loops, if you don't have the real-world evaluation, you can't see the error, let alone fix it.
And so it's really easy to say that your product's safe, it's responsible or high quality, but ultimately those are just words. And at some point, you need to turn that into something specific and operational. And so this framework is just one way of doing that, but it's certainly not the final answer. But at least gives us a way of being really specific about quality, risk, and what happens when the product gets something wrong. And so that brings us back to the standard that everyone in this room, we all need to set for clinical AI. If clinical AI is going to shape what gets trusted, captured, acted on, generic is not good enough. It's something a tool has to keep earning through deliberate scale, feedback loops, and intentional systems that surface what's missing. Independent evidence that challenges what we think we know is absolutely essential, and setting a standard that keeps rising as the role of this technology becomes more consequential. And so this isn't an abstract question about the future. This year in Australia, the estimations are that at least 42 million consults are going to involve AI. And so this number's only going in one direction, right? And so we actually need to decide this now, and we need to confront this now. And so we're not talking about a standard we might accept one day. We're talking about what we need to do now. And so that matters to everyone in this room, whether you're building, buying, deploying, governing, or even using these tools in care. We need to take a look and really, really deeply interrogate what these tools are and the evaluation framework and what defines quality for the ones that we let into our practice room. And so we all have a stake in that future, because one day us or someone we love will be on the other side of these tools as a patient. And so when that happens, will want to know that it's been built with the depth and care that clinical work deserves.
And for me, it comes down to just this. Next week, I'll be in clinic, and sitting across from me will be a patient. I need to know, like really need to know, that that tool belongs there if I bring it in an AI tool. So if it belongs, the potentials are enormous. It can make me a better doctor. It can make me connect with my patients instead of via the screen or via paperwork. And it can improve my patients' health outcomes. But if that tool doesn't belong there, if it's been built too fast, too generically, too broadly, then that's a risk to my patient, and that's not a standard that I'm willing to accept in the consultation room. And if you're in the consultation room or a loved one sitting across from me next week, you wouldn't accept that either. So if you're in this room, you're part of this conversation. Come find us and join us. We'd love to chat. Let's build this exciting future in AI healthcare together, responsibly. Thank you very much.
Thank you very much. Have you got some questions for these two? It's so good to hear like scaling deliberately and not moving fast and breaking things. It's just such a relief, isn't it? Any questions? Maybe. There's one coming.
I'd like to understand the extent to which generative and determinative... Oh, here we go. There you go. Just for that.
Thank you so much for that. I'd just love to look under the hood and better understand the extent to which determinative and generative AI is in the model. How do those two pieces of technology interface?
Yeah, so generative is like basically where you can think of it as, so like most deterministic is like a calculator. When you put in 2 + 2, it will always equal 4. Something that's generative, you put in the same inputs and it won't always give the exact same outputs. So if you ask ChatGPT the exact same question, right, it won't give you a verbatim response every time, just as a context for that question. So LLMs are very much generative. And so that's the kind of, you can think of that as like a generative engine, but then what we need to do, and part of being safe, is putting actually deterministic guidelines and frameworks around what goes in and also what comes out. So in terms of our engine, that's like a rough kind of overview, but the LLM tools are just inherently non-deterministic, yeah.
Everybody can go see Lyrebird. They're on the stand in the show floor for the rest of the duration of the show. Thank you.
Thanks so much.
Thank you.